It looks like the son has threadworm, so we can sell some mebendazole over the counter as he's over the age of 2, and we must recommend that the whole family is treated. Although as mum is pregnant, she will need to be referred to the GP. We can give additional advice as well, so strict hygiene measures in place for everyone in the family. We're now going to move on to constipation. So this topic was covered in the Responding to Symptoms lecture for gastrointestinal conditions, but here we're going to focus more on the child aspect. So similar symptoms: difficulty in straining and passing stool less often. There might be some tummy ache, might be off their food. In children, you'll see behavioural changes, so they might be irritable, unhappy, they might become anxious about going to the toilet, they might be soiling their underwear. And it's important to recognise these signs early because it can become a chronic problem. Constipation can be caused by an underlying disease or condition, or it can be idiopathic. And this is where we're not really sure of the main cause. So diet has a factor. There can be lack of fibre and inadequate fluid intake. And with children in particular, any new changes in their routine, so for example starting a new school or a nursery, that can cause some emotional stress and lead on to stool holding. So this is when they're holding the stool in, they're not wanting to go to the toilet, and they're ignoring that urge to go to the toilet. This in turn makes the stool larger, and then it's even more painful to go, and then you get stuck in this vicious cycle. It can also become a problem when you start potty training, or become apparent when you start potty training, and this is because up until that point the child hasn't really had to think about going to the toilet, and then all of a sudden they have to think about other factors, and it can become quite an issue. What do we need to know? We need to know who it's for, the age of the child, what are their main symptoms, how infrequent are their bowel movements compared to what they normally were. Is the stool dry and hard? Is it large? Is it small? And are there any other symptoms? So is there any abdominal pain and nausea and vomiting? This could be a sign of appendicitis. And is there any blood in the stools? How long have the symptoms been present? So this is another thing, again, that parents or carers will try come and see you fairly early on after symptoms have begun. Have they tried anything yet? And is there any underlying medical conditions that could be causing the problem? Or are they taking any medication? Practical tips we can give: increasing fluid in the diet and increasing fibre. And as we said in the gastrointestinal lecture, that you shouldn't increase that amount of fibre too quickly. That needs to be done gradually, otherwise it can cause bloating and flatulence. If you suspect something like a intolerance to cow's milk, then you could try a different milk. Encourage the child to go to the toilet regularly, and when they do go to the toilet, try and distract them as much as you can. So little things like you could read a book or read a story while they're trying to go. Basic principles of treatment to exclude any underlying cause, and the main thing is really to establish a regular pattern of going to the toilet. Treatment options that we have: lactulose is an osmotic laxative, but it can take about 48 hours to work, and you still need to drink plenty of water whilst taking the medication. It's a stool softener and can be used in those aged 1 year and over. Aspergillus is a bulk forming laxative and can be used in those over the age of 6. Senna is a stimulant laxative and can be used in those above the age of 12. And that one acts quicker, it acts in 8 to 12 hours. Macrogols are available on prescription, so they would need to see a GP to get those. Glycerin suppositories is an osmotic laxative, and look, they work very quickly, so they can work within 15 to 30 minutes. And it's important to continue the medication for several weeks after a regular bowel habit has been established to prevent it from reoccurring. When should we refer? If there's any severe abdominal pain, any rectal bleeding, or if there's any blood in the stool, vomiting, if there's really severe pain on trying to pass stool, and any persistent constipation despite trying diet changes, increasing fluid take, or failed treatment. There are several causes of nausea and vomiting in children, so it can be gastroenteritis, it might be a respiratory condition, any problems with feeding such as reflux, meningitis, and also just if they're excited or overexcited or nervous. There is no treatment over the counter to stop nausea and vomiting. The main aim of treatment is to rehydrate. So you can recommend small, frequent sips of water, but also you can use the oral rehydration sachets to replace both fluid and the electrolytes and glucose. Any unused solution should be discarded after an hour or 24 hours if kept in the fridge. We should refer if there's any signs of dehydration, if there's frequent vomiting for more than 24 to 48 hours. If you think there's any signs of the child being systemically unwell, or there's any signs of fever or infection. As with vomiting in adults, if there's any indication of any blood staining within the vomit, and any of the general warning signs for children. Bacterial meningitis is a serious infection that causes inflammation of tissues around the brain, and if not spotted quickly, the child can die quite quickly. Any symptoms need urgent referral, and they should be sent to A&E. Most common are a fever, high fever, rash, nausea and vomiting, neck stiffness, and photophobia. With regards to the rash, as we covered this we also covered this in the skin lecture for responding to symptoms, but you can do the tumbler test or the glass test to check whether the rash is non-blanching. And if it is non-blanching, that is a sign of meningitis and you need urgent referral to A&E. So we've gone through all our common child conditions, and now we're going to have a little look at some consultation skills and be able to adapt, so we can adapt them towards children. It is difficult getting medication into children. We shouldn't be mixing medicines with large quantities of food or in baby's bottle. Although this does mask the taste, it's difficult to ensure that they have had the full dose. So if they haven't completed that meal or completed that whole bottle, they're not going to receive the full dose. Children under the age of 5 generally need liquid formulations, but don't assume all children want liquid preparations. Some of them can have quite a bitter taste. My daughter would always refuse liquid medications because of the taste and would always insist on having tablets. So always double check what is preferred. Sugar-free medications should be provided where possible, and if travelling, you can give the option of soluble tablets. Different tips for applying or administering different types of medication. Eye drops. You can place the drop in the inner corner of the eye, and that should still drain into the eye even if the eye is closed. With eye ointment can be a bit more tricky, but you can try and apply that when the child is asleep. Chloramphenicol eye drops should be kept in the fridge, so if you are travelling, that's no good and you might have to use an eye ointment instead. With eardrops, you can wrap the child or baby in tightly in a blanket, and this helps to minimise movement. Pull back the earlobe to open the ear canal, and then you can administer the eardrops inside the ear, but try not to touch the ear with a dropper because this will increase the risk of transferring infection. With nasal drops, you can lay the child across your lap with their head hanging down, or with small babies and young children, wrap them in a blanket. To remove mucus, you can try with cotton wool, and generally warm drops are better tolerated. No more than 2 to 3 drops should be used at once. With suppositories, that can be a bit more tricky. Try and lie the child on their side and pull up their knees. You can lubricate the suppository with Vaseline to try and help with the insertion. After inserting the suppository, the advice is to try and hold the buttocks together for 5 minutes, but I wish anyone luck trying to do that with a child. Giving liquids via a spoon, ensure the child is sitting upright or standing, and try and lift their chin a bit because this helps to prevent choking. Always make sure a medicine spoon is used. A normal teaspoon at home might not contain the correct volume, and have a drink ready to hand so the child can drink after the medication to wash it down. With tablets, place them on the back of the tongue and make sure they have a drink to swallow it down afterwards. Some tablets can be mixed with the food, but not all tablets can be crushed, so you need to check with individual manufacturers to see if that can be done. Normal basic information, so check how long will the supply last, is there going to be any remainder, and if there is, do they need to discard it or do they need to return it? Check the expiry date. So sometimes once a medication is open, then the expiry date might be reduced, and some antibiotic medications, liquid medications, once they're made up, may only have a 1 or 2 week expiry date. And ensure the parents or carers or whoever is administrating that medication is washing their hands before they do it. Hopefully now you're a bit more familiar with the sort of conditions that we can see in a community pharmacy with regards to children, thinking about how you can diagnose those issues, what sort of questions you need to ask to differentiate between more serious conditions, and know what off treatment you can offer over the counter and any non-pharmacological interventions. There are some quite useful references that have been put on Blackboard to give you some extra information, so I advise that you have a look through those in your own time. And if you have any questions about any of the content, then please do not hesitate to email.